Hello, my name is Angela Gibson, and I'm honored to represent my lab and provide a brief overview of our paper entitled Lighting the Way for Necrosis Excision Through Indocyanine Green Fluorescence-Guided Surgery. In surgical practice, the visual evaluation to determine if tissue is living or dead is often subjective and may not be equivalent to what is occurring microscopically. We and others have previously shown that surgeons are not very precise at the removal of necrotic tissue in burns, and this often comes at the expense of overexcision, which leads to the removal of viable tissue. If left in place, this viable tissue could have the potential to contribute to healing. Another related problem in wound healing is understanding which tissue is irreversibly dead compared to tissue where there is reversible cellular damage, for example, due to inflammation, that may need additional therapies to enable recovery. Indocyanine green, known as ICG, has long been used to identify blood flow, or conversely, the lack of ICG identifies ischemia as a surrogate marker for necrosis. Recently, fluorescence-guided surgery has gained great interest in a variety of disease processes, such as cancer and lymphatic mapping. Furthermore, recent studies have used delayed imaging of high-dose ICG to identify tumor borders to guide excision when inflammation around the tumor leads to ICG sequestration. We hypothesized that in inflamed burn tissue, ICG leaks out of the permeable vessels and binds to necrotic tissue, and therefore, SWIG imaging of burn wounds could be an objective tool to assist surgeons in precise burn tissue excision. First, using mice, we demonstrated that ICG angiography and SWIG signals are dependent on ICG dose and length of time between burn injury and ICG injection. Next, we used human skin grafted onto athymic mice and showed that ICG angiography and SWIG have complementary inverse fluorescence. And finally, in our human burn patients, we found that SWIG fluorescence levels reduced after excision of the necrotic burns. Microscopically, we showed that the fluorescence is localized to the layer of necrotic tissue immediately adjacent to inflamed but viable cells. In conclusion, we have visual, microscopic, and fluorescence data to support SWIG imaging as a potential modality to objectively prognosticate burn wound healing potential and guide intraoperative burn excision. Further studies are needed to define ratios of fluorescence intensity values to guide surgical decision-making and to better define how ICG is retained in necrotic tissue to enhance utility of SWIG and other disease processes. Thank you.